Okay, good morning, everyone. The next presentation comes from Oregon Health and Sciences University. Will be presented by Dr. Tobias and is entitled Standardized Perioperative Care Reduces Colorectal Surgical Site Infection, a Western Pediatric Surgery Research Consortium Multicenter Analysis.
Good morning. Thank you very much for the opportunity to present our work. Our group has no disclosures. It's estimated that pediatric colorectal surgeries contribute to 7.5% of all surgical site infections, despite comprising only 2.5% of the surgical caseload. Retrospective data have shown that standardizing perioperative care in pediatric colorectal surgery reduces rates of SSI, but to date, multicenter prospective data are lacking. To address this gap in knowledge, the Western Pediatric Surgery Research Consortium conducted a multicenter study evaluating a perioperative care protocol nicknamed the colon bundle. We hypothesized that implementation of the colon bundle would reduce the 30-day rate of postoperative superficial SSI. The colon bundle consists of 8 elements and was devised according to best practices from both the adult and pediatric surgical literature. Preoperative elements are umbilical cleansing and antibiotic administration within 1 hour of incision. Intraoperative elements are use of a leak test, use of a dedicated closure tray, glove change prior to skin closure, and maintenance of normothermia. And postoperative elements are stopping antibiotics 24 hours post-op and examining the wound at 48 hours post-op. In addition to these required elements, there are 3 optional elements in the bundle: a preoperative mechanical bowel prep, a preoperative chlorhexidine bath, and placement of a subcutaneous drain in grossly contaminated cases. The study was a mixed retrospective and prospective chart review at 10 participating children's hospitals. Children ages 0 to 18 who underwent a colorectal procedure were included. Isolated anal procedures and procedures without primary abdominal closure were excluded. Primary outcome was superficial SSI within 30 days of the index case. Secondary outcomes included bundle compliance, length of stay, and rates of complications. The colon bundle was implemented as standard of care for eligible patients after October of 2019. Eligible patients between August of 2020 and January of 2021 were prospectively studied, allowing for an 8-month transition period after formal bundle implementation. A retrospective cohort was also studied, consisting of eligible patients from May to October of 2019. We considered 2 study designs, one comparing retrospective and prospective cohorts with respect to the primary outcome, and 2, a comparison of patients from both cohorts according to level of compliance, defined as either low compliance with 1 to 4 bundle elements completed, or high compliance with 5 to 8 bundle elements completed. Since the colon bundle was already being used at certain consortium hospitals prior to its formal implementation, we opted to study the impact of high compliance on rates of superficial SSI. In total, 336 patients were included in our analysis. 138 fell into the low compliance cohort and 198 into the high compliance cohort. There were no differences between low and high compliance cohorts with respect to age or sex. Preoperative diagnoses and comorbidities were similar, with the exceptions of a higher percentage of IBD in the high compliance cohort and more congenital heart disease in the low compliance cohort. Sepsis was also more common in the low compliance cohort, with more frequent vasopressor need, but none of these septic patients developed a superficial or deep SSI. Importantly, we showed a significant increase in the level of bundle compliance after formal implementation. High compliance was demonstrated in 48% of patients in the retrospective cohort compared to 72% in the prospective cohort. Delving further into our data, the most common surgical intervention was small bowel to colorectal anastomosis. More exploratory laparotomies were performed in the low compliance cohort. Small bowel to colon or rectal anastomosis were performed more frequently in the high compliance cohort. And there was no difference between groups in terms of procedure acuity or wound class. Notably, we found that 30-day rate of superficial SSI was significantly lower in the high compliance cohort. Logistic regression confirmed the independent association of high compliance on reduced rates of SSI, but interestingly, no individual bundle element was found to be independently significant. Median total and postoperative length of stay, 30-day rates of readmission, reoperation, organ space infection, and anastomotic leak were not different between groups. In a secondary analysis of the impact of mechanical bowel prep, which remains a contested practice in colorectal surgery, there was no difference in rates of bowel prep between the low and high compliance cohorts, but we did observe that more bowel prep was performed in the prospective cohort. There was no difference in rates of superficial SSI between the retrospective and prospective cohorts, so the clinical significance of this remains unclear. In summary, we demonstrated more than 70% compliance with a colon bundle at 10 children's hospitals and showed a significant increase in compliance after formal implementation. Odds of a superficial SSI were 2.55 times higher in the low compliance cohort. Lastly, the role of mechanical bowel prep remains unclear. Important next steps for our group include further investigating the impact of bundled care on other clinical outcomes and devising consensus guidelines. Thank you very much.
Thank you so much. Paper is open for discussion. Sorry, I can't see the back of the room there because the light is shining in my face, but can you see it? Well, yeah.
Morning, Imran, Corpus Christi. ICG fluorescence angiography has been used to reduce the risk of leak rates and infections in adult surgery pretty extensively, and now it's starting to be reported a lot more in kids. Are you guys thinking about including that in your bundle?
It's a very good point. We had not yet thought about it, but it would be a good area for further study.
Andreas Myers from the Upstate. You had 25% of non-compliance. Do you do a sub-analysis and find out why that was, what was not done, and why did that happen, that they were not compliant?
That's a very good question. Implementation varied across the consortium hospitals. There was a lot of work that was done into education of surgeons and OR staff. There were dot phrases that were used to standardize care and checklists that were used, but there was variability in terms of buy-in and how aggressively the colon bundle was implemented from institution to institution. So the variability in compliance has to do with that.
Anything, Andrew, from your side? No? Okay, thank you so much.
Thank you.